we've got a couple options for the intercondylar fossa. I'm going to go ahead and take your pant leg down for this. The Patella is probably the most common because it's an AP position, and so rather than requiring your patient to roll over onto their stomach, most people will do the AP but clear method. I'm going to place a sponge under her knee, get a clean 14 by 7 or a 10 by 12 IR, and I'm going to place this up as far against her thigh as I can get it, and then put approximately 30 degrees of flexion into the leg. The book talks about the femur forming a 60-degree angle, but then when you drop the tib fib, that makes the tib fib's angulation up from the table about 30 degrees. So we're putting about 30 degrees of flexion into the tube, and then I'm going to match the rotation of my tube to the flexion of her leg. So whether it's exactly 30 or close to it, I'm just for effect, I'm going to bring this down just a little bit. And I can tell right now that the plane of my tib fib is not quite aligned with the plane of the bottom of the collimator box. So I'm going to need to rotate a little bit more. And now I'm right about 30 degrees. And now the plane of my tib fib and the plane of the collimator box are parallel. So I know that my central ray is perpendicular. So once I've got that alignment, then I'm going to get my SID and my center point, making sure that her leg is not rotated medial or lateral. Still going to pass about 1 inch, 1/2 inch below the apex of the patella. And because now my IR is elevated off the table, I'm at about 46 SID. And if we, so what would that be? This is 3 inches off.
So 3 inches would bring it up to 46, and then 30 is 6 down, so about 40. It should read out as 40.
All right, so we'll bring this down to about 40 readout, and then that's working out about right. So I'm coming in 1/2 inch below the apex of her patella. I've got the IR up as far as I can take it, and so my central ray is exiting at mid-cassette. I'm going to adjust my collimated beam. Now we're only going for the intercondylar fossa, so we can collimate down quite a bit, maybe more like 8 by 10 instead of 10 by 12, and then just make sure that my right marker is in the field of view. She's shielded. So basically the central ray is we've bent the knee so that the patella's out of the way, and now we're seeing the fossa that is in between the two condyles of the femur. All right. The only time that I would do the Camp Coventry view, which is what we're going to cover now, is if my patient had a very large thigh and I couldn't get my IR pushed up enough so that my central ray exited at the center. You're going to encounter this quite often. And so what a lot of techs will do is maybe just flex the knee a little bit more, push the IR up a little bit more, play with the angulation of the tube. But ideally, we are supposed to maintain that 30-degree flexion of the knee. So if I were to come across someone who had a large thigh, I would just automatically put them prone and do the Camp Coventry view. Okay, the other option for the intercondylar fossa is the Camp Coventry method. So my patient is turned prone, the shield is now on her back. I have a 10 by 12 IR, and like we demonstrated for the calcaneus, I now have her knee on the upper half of the IR, because by the time my angled beam enters and exits, the central ray will exit at the center of the IR. So I've got her knee resting on the upper half. Your clinical sites will most likely not have these leg supports, but we're lucky here at Chafee that we have funding to purchase all these positioning aids. So you would rest her foot on something. If it's not a leg support like this, you could perhaps get a large positioning sponge. You can, maybe do this instead, put a positioning sponge. This is actually too long, but you can use a trash can. Whatever they've got available, your clinical site will tell you what they do if they even ever attempt a Camp Coventry view. So I have her knee flex approximately 30 to 40 degrees. You can adjust this. If it seemed like it was flexed too much, you can lower this down. I'm looking to see that between 30 and 40 degrees is where the flexion of her leg is coming up. And then I'm going to match the flexion of her leg with the angulation of my tube. So, like we did when she was AP, I'm going to rotate the collimator until it looks as though the plane of the collimator box is parallel with the plane of her tib fib. And when I'm satisfied that that looks about right, maybe this is more appropriate. So it looks like I'm at 38 degrees, 38 to 40, which that's about what her knee is flexed. Then I'm going to enter the crease at the back of the knee, and my exit point will now be a ½ an inch below the apex of the patella. So if her pant leg was down, but you can tell that this is where her knee is bending. So my central ray enters at the bend in the back of her knee. It's exiting a ½ an inch below the apex of the patella and hitting the IR at the center. So I've got proper collimation all around, at least 1 inch beyond the skin line. And then I'm just aiming for the intercondylar fossa. So my collimation is probably 6 by 6 or 8 by 8 on this. Placing my right marker. This time I'm going to place it upside down so that when I'm viewing the image, I can see my marker facing forward. So you could put it probably on the lateral side, right here. I have shielding, and her leg does not seem like it's rotated, so I would expose that way. Depending on the site, on the clinical site that you're at, you're going to do 2 or 3 views for the patella. Sometimes in a knee series, that's where a lot of physicians will request a sunrise view, which is one of the patellar views. Even though they're not actually asking for a patella, they like to see the sunrise because it also gives a good projection of the intercondylar fossa and the space directly underneath the patella, which in instances of arthritis or sometimes occupational injuries, it helps a physician to see the underneath side of the patella. We're going to include it as part of the patella series rather than the knee series. And if someone actually had a fractured patella, I would probably not put them prone. The reason the textbook demonstrates this prone is because of object image distance, OID. In the prone position, the patella is in direct contact with the IR. In the AP position, it is obviously, 5 or 6 inches away from the IR and creates some magnification. But honestly, if someone had a fractured patella, I would not roll them prone and resting on their broken patella. But this is how it's going to be demonstrated in the simulated evaluation. You can do this tabletop or in the bucky. I think the book talks about it in the bucky. No, it doesn't. It's tabletop. I think it's tabletop. Okay. So I'm going to place the IR directly under her patella. I don't want any rotation of the leg. I want the patella to be directly centered in between the femoral condyles, so there should be no rotation of the leg. I can feel the inferior border of her patella, so I know that I have her patella centered to the IR. There's no rotation. There's 40-inch SID and only about a 6 by 6 inch collimation. I'm only interested in the patella, so I don't need to include femur or tib fib, a very big portion of either one of those. And then you'll see when you get to clinic that on your control panel, you're gonna have to set probably about 5 to 10 kV higher for this, because the patella is not well penetrated on an AP knee view because it's bone on bone. If I'm going to see the patella, I need to penetrate through the femoral condyles so that my patella is well penetrated, and maybe the lateral borders of the femoral condyles will be over penetrated, but I'll see the patella. So this is going to be a 5 to 10 kV higher technique than what you're going to use for your knee. So this is my PA view. I'm actually going to place my marker inverted so that it is shown on the view screen in the correct orientation. She is shielded, and I would expose. All right, now we'll be doing your lateral patella. So I need you to roll all the way back over to your back. And then for the side view or lateral, you're going to be laying on your, which patella did I do? This one. I did your left one.
That's why I'm following you to see which one you're gonna do.
Okay, that was a mistake. So
We can demonstrate the right lateral if you want.
but I did your left.
Uh-huh.
Okay. I'll go ahead and just do your left.
Okay.
That's fine. Okay. So the patella is a tiny little bone. It's about as big as an egg. So I'm gonna just put in maybe 10 degrees of flexion, right? It's not gonna be very much. And I need you to be all the way over on your side. There we go. All right. So I can feel the patella here. Actually, I'm gonna pull your pant leg up so I can show this. So with her leg flexed, you can see the upper and lower edges of the patella. I want the leg to be in a completely lateral position so that the back side of the patella is vertical to the tabletop. There's only going to be about 10 degrees of flexion in this, because if her patella is fractured and I were to bend her knee 30 degrees, I could maybe displace those fractured segments. So there's only a slight flexion of the knee for this. I'm gonna center her patella on the IR. And then my collimation again is not gonna be any bigger than 6 by 6 because I'm only interested in the patella. I'm gonna rotate my collimator so that it is lined up with the long axis. Place my marker in the field of view, and I should get a side view of her patella in profile. Notice that the collimation does not go past her knee here. It doesn't have to because I'm only interested in the patella. She's shielded and I would expose. Okay, and we have one last projection for the patella, which is called a sunrise view. All right, again, do you mind if I take your shoe off?
Of course.
Okay. So as I just mentioned, flexing the patella, if it's fractured, is kind of tricky to do, but the only way you're going to get a good sunrise view is if you have true flexion of the knee. Sometimes this can be accomplished by starting out with just a small degree of flexion and letting the patient work up by just minimally flexing the knee and then waiting a little bit and then trying to flex it a little bit more, rather than just all of a sudden flexing it and creating it pain. So I'm just going to flex her knee up until it's what we would call hyperflexed, at least 90 degrees, maybe more if I can. And then again, this just depends on your patient's ability to do this. So now my patella is sitting up somewhat angled at the top of this triangle. So the bottom of her patella is probably sitting at about maybe a 10 to 20 degree angulation, which means when I adjust my x-ray tube to the end of the table, I'm going to be coming in at a 10 to 20 degree upward angulation because I want my central ray to come in parallel with the back side of her patella. Visualizing this is a little difficult when you're first getting started as a student, but as you do more and more of these and you listen to the tips and tricks that your techs are going to give you, it becomes a very easy, very routine projection. It does require your patient to participate. So generally, I will use a 10 by 12. Sometimes sunrise views are bilateral studies, and then you would have a 14 by 17 and do both knees at the same time. We're just going to demonstrate one side. So I would have my marker on the cassette. I may need to adjust it at the end. I'm going to have the edge of the cassette resting about mid-thigh, and I'm going to have my patient holding it. If they're having difficulty, if their arms aren't long enough, you can always prop them up with a sponge. You can have them sit. I will let her have some support. So now she's kind of in a reclined seated position. It's probably a little bit easier for her to hold this. And then I'm going to take my tube down to the distal end of the table, and like I said, I'm probably going to be angled about 10 to 20 degrees toward the ceiling. And then depending on how the table moves and where my my tube is, what I may need to do is pull my patient down to the end of the table. Wish we had a sheet on hand. Oh, there we go. Okay, come around to the end here. So I can see where my patella ends, and my central ray is entering a 1/2 inch below that, and it creates sort of this rounded shape on the IR. That's where I'm able to tell that my patella is going to be in profile, because I can see the shadow of it right at the center of my cassette. Move my marker into the field of view. It's entering just below the patella, and it's going to go on the posterior side and right in between the femoral condyles. It comes out looking like a mountain peak with the sun rising in between it, and that's why it's called the sunrise view. This method is called the Setagast. We're moving now into the femur. Right, so generally, we know that the femur is the longest bone in the body. Even on people who are less than 5 feet tall, their femur bone is generally longer than 17 inches. So because it measures more than 10 centimeters in most cases, this has to be a Bucky projection. We need a grid. And so I'm forced to place the IR lengthwise in the Bucky, which means at maximum I only have 17 inches of field to work with versus the almost 21 inches when we were able to shoot diagonally for our humerus and our tib fib. So because of that, we need to do 2 projections for the AP and 2 projections for the lateral. For the AP, I'm going to get the upper femur as far down as I can go in 17 inches field of view, and then I'm going to swap out and put a 10 by 12 in, overlap about 3 inches, and now I'm getting my distal femur and including the knee joint. So we're going to do 2 projections to get the equivalent of 1 AP view. To figure out where the top of my cassette is going to be, I'm going to feel for her ASIS, and that is where I'm going to line up the top of my IR. So ASIS, the top of my IR is here, and by doing that, I know that I am approximately 1.5 inches above where the head of the femur is going to be. This is a perpendicular central ray, 40-inch SID, approximately 8 by 17-inch collimation. Because the femur is not 14 inches wide, I can collimate into about 8 inches. I'm going to be at 40-inch SID. And you can go up to 43 on this because we want to take advantage, we want to get as much of the femur on our AP view as possible. So I am actually going to increase this to 43 because you can do about 3 inches before you have to start changing your technique. So I'm aligned and detented. Now keep in mind the beam is coming out kind of at an angulation, so even though the top of my IR is even with her ASIS, the actual collimated light field is going to be maybe 1 inch below that. But by the time it passes through her body and exits, it will have included the hip joint, and my light field will end up being even with the top of the IR. In order to see the greater trochanter in profile, I start out with the leg vertically, and then I'm going to medially rotate maybe about 10 or 15 degrees. A lot of times what you'll see the techs do is have the patient touch their toes together, because with their toes touching, it gives them something to keep them steady. If I didn't do anything with the unaffected leg, I don't know if this patient's going to keep this degree of rotation. So I would have her touch her toes together. This keeps her hip in internal rotation. It's going to allow me to see the greater trochanter. Now, if this was trauma, boy, my voice just changed. If this was trauma, we would not be internally rotating the leg. All right, so my right marker is in the field of view. Her femur now is down the long axis of the image receptor, and that is my AP view. I'm still shielding my patient's ovaries, but I've kind of angled the shield just a little bit so that I'm not interfering with the anatomy of interest. Okay, so now I've done my AP proximal femur. I'm going to swap out my 14 by 17 for a 10 by 12. Okay, I'm going to change my collimation now. I don't need 17 inches, I need 12. And so what I want to do is make sure that I am overlapping 3 inches. So it's at 17 inches of collimation, I got down to this far on her femur. I want to make sure that I have overlapped about 2 to 3 inches. So what I do is I place my hand at the very bottom of the light field, and now with 10 by 12 inches of collimation, I'm going to make sure that that same 4 inches, 2 to 3 inches, is included. So my hand was in the upper field of view, and now my hand's in, or it was in the lower field of view, now it's in the upper field of view. That means that this section of her leg is going to be in both projections, and that's what I want. And my central ray, my field of view, I mean, has also gone beyond the knee joint. So I've included the knee joint and the hip joint, and I've overlapped 2 to 3 inches of about mid to lower femur, so that if there's a fracture, I don't want to accidentally miss it. I've overlapped the bone about 2 inches in each one. It's in the field of view. I'm still gonna, even though I'm not at the hip anymore, I'm still gonna maintain this medial rotation, because I don't want the femur to be rotated in on one and out on the other. I want the same anatomy for both. So I would expose this, okay? And then the lateral, since I'm already centered over the lower half of the femur, I start out with the lower half on my lateral and then move up to the upper half. So I do AP upper, AP lower, lateral upper, so that I'm not moving my patient or my tube back and forth. I'm pretty much kind of staging it to have, minimal work. All right, so what I need you to do now is roll completely onto your right side. And I'm going to have you draw your leg up just a little bit. Okay. Again, I want to get the knee as lateral as possible, so her femoral condyles are going to be superimposed. I'm going to place the shield up here. This time I'm not doing the knee, so there is no cephalad angulation. It's perpendicular because I'm aiming at the femur. And I want to be sure that I've included the knee. So I'm going to feel for the bottom of her patella, make sure that my light field goes at least beyond the knee joint. And this is my distal lateral projection with my right marker. I would expose that. Then I would switch back to a 14 by 17. This time I'm going to have you take your leg behind you. There you go. So I really, at this point, I don't want my patient to be scooting around at all. So I'm going to just twist, I'm going to twist her a little bit. The reason for that is I want the femur to still run down the long axis of the table. How she was originally, you know, her femur's angled like this. So by me twisting the pad just a little bit, I've got her femur running down the long axis of the table. I'm going to open up my collimator now back to 17 inches. Feeling for her ASIS. My upper border is at her ASIS, so I know my hip joint is on there. I still want to get about an inch beyond the skin line, so I may open this up just a little bit. And again, I'm going to try to shield her as much as possible without getting my shield in the anatomy of interest. So that is, and now this is actually more than, this is more like 17 inches, so let me go up a little bit. So this section of my femur was included on my lateral distal femur and is now included on my lateral upper femur, proximal femur. So I know that this section here is going to end up in both projections.